Good morning, everyone, and welcome to PerfWeb. I am your host, Joe Basha, and I am here with my dear friend and colleague, Dr. Samir Patel, perfusionist extraordinaire. And that's right, right? You put the first, the highest one first, right?
Yeah.
That is how that.
I thought it was the one you used, but you're the one that informed me it's the highest one.
The highest one is first.
Okay, yeah.
And so good. We got that right. Thank you. Anyway, we're going to have a really interesting program today. We know it's going to be about CMS and perfusion salaries and the squeeze, if you will, on hospitals and how that's going to affect us, staffing, what our shortage is predicated on. There's just a whole cornucopia, if you will, of concepts that we're going to be talking about today. We're actually going to do something really different. Let me get through the basic opening remarks. I know I get ahead of myself a lot of times. Contact us right down there. Contact us at perfusion, contact@perfusioneducation.com. Send your email, if you have a question or you have a comment or you have just anything you want to participate as a lecturer, we are happy to have you. We can bring you in remotely. There's no need to travel, but we'd love to have you come to the studio. I think you would really enjoy it. It's a pretty high-tech place to be, and I think that I'm very proud of it. I'm very proud of the work that everybody has done, especially Magic and David,
Yeah.
who put essentially all of this together so that it works the way it does. Our crawl bar that you will see throughout the course of the program right there, that goes on, and it is a way you can find our various websites. You can find our social media platforms or spaces where you can please like us, follow us, share us, subscribe, notifications, do all of those things that help to bring notice to us, because that helps us in this channel continue to operate. As everyone knows, we do have a paid subscription where if you are looking to get CEUs from the American Board, ABCP accredited, like this program is accredited, then that you pay for those CEUs. However, because that costs us money to obtain those things. However, the education, these lectures are all free to all of our colleagues that may be watching. So I want to make sure that everyone understands that distinction, because I think it's something that really matters to me. The MediWeb app, I think this is another thing that we have created that I'm very proud of. This app has various different elements to it. It has perfusion, which has perfusion quick calcs inside it, where you can put all of your patient information in the morning and get all of the information you're going to need to conduct your case safely on that patient. It has a hemodynamics, it has a converter, it has an ECMO space. This is appropriate for perfusionists, ECMO specialists, CRNAs, anesthesiologists, really any critical care doc, anybody taking care of critical cardiac or critical care patients. It also has in the bottom left corner you see there, an IV rate dose calculator. That is also a standalone app. Now this app is only $2.99, but for the full app, but for the IV dosage and rate calculator, that's only 99 cents. And you can find it on Google Play, you can find it on the Apple App Store. Both of these are incredible resources and gives you some very good information at your fingertips if you're in the middle of a procedure and need to know something, whether it be the DO2, whether it be SVR, whether it be what should the drip rate of your dobutamine be, your epinephrine, whatever drug you may be giving, it gives you that information at your fingertips. Moving on from there, our podcasts, our programs are all converted to podcasts, and you can listen to them on whatever your favorite podcast streaming platform may be, Spotify, Podbean, all of the various different ones that are out there. So that's another thing that you can do. With that said, let me introduce, if I may, even though I have introduced him a few times, but I don't think I've ever really introduced Samir that effectively. Can we go to widescreen? Oh, you wanted me to do that? Okay, there we go. Yeah, I think I told them already. They've seen it a million times. We're just going to move on. So this young fella next to me here is Dr. Samir Patel. He is he graduated from Windsor University School of Medicine in St. Kitts and Chicago. He did his residency and fellowship in internal medicine and neurology in India. He practiced as a neurologist at a stroke clinic for 8 years. He returned to the United States and decided that perfusion was a pathway of passion, a path of passion for him. I hope I got that right. I think that's about right.
Yeah.
He's graduated from the UT McGovern School of Medicine and Perfusion Science in 2024 and currently works here in Houston with me for HET, Houston Extracorporeal Technologies. So I want to tell you very much that it's a very impressive CV that you have.
Thank you.
And you also have, and I think this is really important, you bring a lot of value, I mean, to the organization where you work. So I feel very privileged and quite frankly very proud to have the relationships that we have, we have and work together. I've learned a lot from you in this relatively brief period of time.
I call you my friend, more than my boss.
Well, I appreciate that. But with that said, I also wanted to say that Samir does a podcast, which I think you might find very interesting. We have a variety of them, but it's called Paging Dr. Samir. Can we throw that up? That should pop up here in just a second. There it is, right there, Paging Dr. Samir. And if you want, can you just show our full complement of everything that we do? There we go. And you can find this on mediweb.us. And you can see that we have a whole variety of different programs. Vicki Carlisle has hers at the bedside. Vivian, of course, has something with vibes. I can't read it from here. Please forgive me. Vitals and Vibes. There you go. And Becky Bolkovac with your Grounded. And we will be adding more to that. We have another program that we're going to be putting together, and we're going to actually, I think we're getting really close to airing our very first one.
It's going to be the funnest.
And it's going to be called Perfusion in Jeopardy. Now, that will be a podcast, but it will be a video as well, or live, rather, here in this studio. They'll be over there, the Mindy Navarrete, who is the host of that program. You didn't see it up there yet. And she'll be asking questions like Jeopardy, the program Jeopardy, in the form of they'll give the answer. We have to answer in the form of a question, and there'll be 3 contestants. And but we're calling it Perfusion in Jeopardy because I think you guys are going to find it quite entertaining. These are things we're supposed to know, scientific things that may be on the board exam and so forth. So I think that program is going to be a lot of fun. But that program is going to be approved. I'm going to submit it for approval, correct that, to the ABCP. I don't see any reason why it wouldn't be, because I think it's going to be highly educational, but I think it's also going to be tremendously entertaining.
Absolutely.
Okay, so let's get back to what we're going to do today. Today is going to be a very unique day. I'm going to do something strange. The following narrative that you're going to listen to is generated by AI on the topic of Medicare pay cuts versus perfusion demand and salary. And all of what they discuss, this AI-generated pair of people, is predicated on the data that I got out of the various evidence-based, published, reputable journals, and submitted to it to distill down into a basic narrative. Now, during this program, you will be able to submit a question. Magic will put it up. I will read the question that you have, and the same applies to you and applies to me, and we can ask that question while they're talking, interrupt them in the middle of their conversation to get a very detailed answer to what that question may be.
This is crazy.
While that happens, we can pause it, and Samir and myself
Yep.
can also add to
Yeah.
that dialogue. Once this is done, and it's about 20 minutes, once this is done, then I am going to take all of that same data that they used in slide form, and we're going to go over it again to reinforce some of the lessons that we are going to learn from this narrative. So this is somewhat of an experiment for me.
Oh, yeah.
But I think that I'm excited about it, and I'm
Yeah.
trying to, even in my advanced age, trying to make myself adapt to the current technological environment in which I am still living, working, practicing, all of those things.
Right.
So I feel it's really important, even at my age, to not say, "Oh, we didn't do it. I never had that when I was." Well, I could say that.
Yeah.
I never had that when I was younger. We just did this. But that's not reality.
No.
You can do that, but you become a dinosaur.
Right.
I'm not ready yet to be a dinosaur. So I'm
Sure.
still learning, and I'm still going to keep coming up to bat and
Right.
seeing what I can do with the advancements. I find
Right.
it very exciting, and I'm just thrilled.
I mean, things are changing fast, right? Like, you have to kind of go with the times.
Yeah, I'm
And
dizzy
glad,
from the
and
changes.
I'm glad that you are.
Well, and I told Magic, I don't know, 2 years ago, we should really invest in this AI thing, and he argued with me all the way to the end of the day. You know?
He's
Yeah.
completely being sarcastic, people.
Go ahead, you were
He
saying.
was the last person to come on board.
Yeah, it's true.
I was just telling him about a conversation me and him had maybe a little less than a year ago. We were driving to Alabama for an NRP case together, our first case together.
Yes.
This is when Joe taught me how to do NRP. But yeah, that whole time, I think we talked for almost 2 hours about how much he hated AI, and now look at him.
This is true. Okay.
This is good, though.
All right.
This is good.
So let's do this, all right? So you got your pen and paper.
I do.
I have my pen and
Yep.
paper.
Mhm.
Audience who are participating, have your pen and paper ready. If you have a question, ask it. If I have a question, I'm going to ask it. If Samir has a question, he's going to ask it. So without further ado, I'm going to start the presentation. And if you look down at the bottom where it says Medicare pay cuts versus perfusion demand, you see that little line? That little line is going to be moving as they are talking. So you will know whether they are talking or somebody else is talking. And I think that's a good visual cue as to where we are in this process. So there you go. You ready, David? Everybody's ready? Okay, here we go. Nope, we're not ready.
Cardiology department. Right. And I mean, more importantly, how do hospital administrators balance that
Hold on.
shrinking budget while they're simultaneously?
Okay.
How does a hospital get a federal pay bump, but somehow end up taking a 7% pay cut across its entire cardiology department?
Right.
And I mean, more importantly, how do hospital administrators balance that shrinking budget while they're simultaneously trying to hire, 25-year-old medical specialists who are currently demanding $50,000 sign-on bonuses just to walk through the door?
Yeah, it is the absolute definition of a structural economic collision. You have federal policy pulling in one direction, and then the harsh realities of the medical labor market just pulling in the exact opposite.
Exactly. And we are diving deep into that collision today. For you listening, our mission is to explore how massive federal policy shifts directly impact the highly specialized, fiercely competitive world of cardiovascular perfusionists. And if you aren't familiar, those are the highly trained specialists who literally keep patients alive by running the heart-lung machines during open heart surgery.
Crucial job.
Unbelievably crucial. So to map out this entire ecosystem, we're pulling from a pretty fascinating stack of sources. We've got the American College of Cardiology's brief on the 2026 Medicare physician fee schedule, live data from an AMSEC job board, a strategic staffing paper on cardiovascular economics, and a Walden University dissertation on employee retention.
And really, the
I
contrast
heard
in
that. I
those
heard that,
sources
yeah.
is what makes
And I
this
couldn't
so
believe you did
compelling.
that.
We are looking
You're
at
using MSEC data.
sweeping macro-level government regulations right alongside the micro-level human consequences,
You're just using
down to
their
the
job
actual
data, though.
psychology of why a surgical team member decides to quit their job.
Yeah, the human element. But let's start with the macro catalyst. We're looking at the Centers for Medicare and Medicaid Services, so CMS, and their 2026 Medicare physician fee schedule final rule. On paper, if you just glance at the headlines, it looks like a win for healthcare providers. The conversion factor is rising. It's going up to $33 and about 57 cents for qualifying alternative payment model participants and $33.40 for non-qualifying ones.
Oh, okay.
And this includes a baseline 2.5% increase stemming from the One Big Beautiful Bill Act that was passed by Congress.
Yeah, so a hospital finance executive. Oh, hey there, what's up?
Yes, when you said qualifying versus non-qualifying participants, can you please explain what you mean by that?
That is a great question.
Absolutely.
Okay, let's unpack this.
It connects directly to how Medicare structures incentives.
A qualifying alternative payment model participant is essentially a provider group or hospital that has chosen to participate in specific value-based care initiatives set by CMS.
Yes, these are models that shift the focus away from pure volume of services.
Instead of just paying for every service, CMS rewards providers who meet certain quality benchmarks.
Like reducing readmissions or coordinating care better for complex patients.
When you qualify for these models, CMS gives you a slightly higher conversion factor.
That's why the qualifying rate is about 17 cents higher than the non-qualifying one.
It's a financial nudge to encourage providers to move toward these complex, outcomes-focused payment systems.
And that tiny difference adds up to millions of dollars in revenue for large hospital systems.
It's CMS leveraging payment policy to drive institutional behavior.
Exactly. So a hospital finance executive looking at that top line number might initially assume their cardiology department is, breathing a sigh of relief.
The baseline rate is going up, which normally implies broader financial breathing room.
Okay, let's unpack this.
Because here is the plot twist.
Oh, yeah.
Despite that baseline increase, overall cardiology facility-based services are actually projected to decline by 7%.
Wow.
It completely breaks a hospital's forecasting model for the next fiscal year.
How do you give a sector to raise and still hand them a 7% pay cut?
If we connect this to the bigger picture, we have to look at the structural adjustments CMS is quietly making underneath that top-line number.
First, CMS is applying what they call an efficiency adjustment.
Right.
They are instituting a permanent 2.5% reduction to relative value units, or RVUs, for nearly all non-time-based codes.
And since RVUs dictate the full weight of how much effort a procedure takes, and therefore what it pays, a permanent cut there acts like a compounding tax on the hospital's entire surgical revenue stream.
Exactly. And CMS is justifying this by arguing that medical teams naturally get faster and more proficient over time.
Right.
They are assuming that new technologies like artificial intelligence, advanced imaging, and automated monitoring inherently reduce the actual human effort required to perform complex interventions.
Oh, yeah.
Yeah, and to compound the squeeze, the indirect practice expenses for hospital services are being slashed by 50%.
50%.
Half. CMS believes that because hospital employment of physicians is rising, the hospitals themselves are absorbing those facility costs.
So they are adjusting the reimbursements downward.
Right.
Okay, I'm looking at this CMS assumption that technology magically reduces human effort, and I have to push back a bit.
Go for it.
It's like giving a pilot a larger, faster, more advanced commercial jet.
That is a great analogy.
Yes, the autopilot is technically better, but the pilot is now responsible for 500 lives instead of 50.
The plane is flying at Mach 1.
Right, the technology didn't reduce the cognitive load or the human effort. It dramatically raised the stakes.
That is a great way to put it.
The tool evolves, but the stakes of the procedure don't decrease.
In fact, because the technology is better, surgeons are operating on older, sicker, more complex patients who would have been considered totally inoperable 10 years ago.
Absolutely.
But CNS is regulating based on a spreadsheet assumption of technological efficiency.
We want to be clear that we aren't taking a stance on the politics of the bill itself.
But strictly from a health economics perspective, the math creates a major squeeze.
Yeah, totally. So if CMS is actively squeezing the reimbursement budget because they think the machines are doing the heavy lifting, we need to look at the people running the literal machine.
The perfusionists.
Right.
And the reality of their labor market is just jarring.
The sources show us that specific, highly complex procedures are getting hammered by these cuts.
Left atrial appendage occlusion, LAAO procedures, are facing a nearly 27% RVU cut.
That's massive.
It is. For context, an LAAO involves sealing off a small sac in the muscle wall of the heart.
This prevents blood clots and strokes in patients with atrial fibrillation.
It requires immense precision.
Yet, while CNS cuts the funding for that precision, the AMSEC job board shows hospitals bleeding money to attract the talent required to perform it.
We're seeing massive sign-on bonuses up to $50,000.
Unbelievable.
And base salaries in competitive markets like San Francisco are hitting anywhere from $200,000 to $290,000.
It creates this intense demographic paradox.
Industry rumors constantly blame a mass retirement wave for these astronomical salaries and severe shortages.
Right, everyone says the boomers are leaving.
Exactly. People assume the old guard is leaving and there's nobody to replace them.
But the objective facts from the 2025 American Board of Cardiovascular Perfusion Annual Report tell a completely different story.
Oh, really?
Yeah, the workforce is actually remarkably young.
Over 50% of the current perfusion workforce is under the age of 44.
Wow, okay.
And looking at the data from 2024, only 74 certifications were lost, which is the absolute lowest level of attrition since the year 2000.
Wait, if the workforce is young and people aren't retiring in droves, why is there such a desperate shortage?
Why are hospital administrators locked in a bidding war that forces them to offer 50 grand just to get someone to answer an interview request?
The answer lies in the horizontal expansion of the profession.
Historically, perfusionists were mostly confined to the traditional cardiovascular operating room.
You know, running the pump for bypass surgeries.
Right.
Today, medical technology has advanced so rapidly that their highly specific skill set is required in entirely new, incredibly complex therapies across the entire hospital.
They're running ECMO, extracorporeal membrane oxygenation, for critically ill patients in the ICU.
And ECMO isn't just a machine you plug into the wall and walk away from, right?
Not at all.
You are essentially managing a patient's entire cardiopulmonary system outside of their body.
The perfusionist has to constantly monitor gas sweeps, blood pressures, and coagulation levels hour by hour, sometimes for weeks at a time.
Weeks.
And they're also managing normothermic regional perfusion, which keeps organs viable for transplant after a donor's heart has stopped, and ex vivo organ perfusion.
That's the one where they're literally keeping a pair of lungs breathing inside a sterile dome outside the body, right?
Yes, exactly, before transplantation.
So the scope of their practice has expanded horizontally, meaning a single hospital suddenly needs 3 times as many perfusionists.
To cover all these different intensive care areas simultaneously.
They're needed in 5 different places at once, and the supply just cannot mathematically meet the demand.
Precisely.
And for you listening,
Hey, yeah, what's up?
So you've alluded to $50,000 sign-on bonuses a few times. I feel like, do you mean like for just small market cities or all cities? What do you mean by who's offering these $50,000 sign-on bonuses and where?
that is a great and incredibly specific question.
And we are happy to unpack it right now.
Okay, let's unpack this. We were seeing massive sign-on bonuses across the board.
Yes, and we were seeing them everywhere from competitive metropolitan areas to smaller regional centers.
For example, the ANZSEC job board showed a $50,000 bonus for a staff perfusionist position in Melbourne, Australia.
But then also $50,000 for a position in Shreveport, Louisiana for new grads.
Right, and you also see them hitting $20,000 in places like Orange County, California, and Tampa, Florida.
So it's not strictly a small market phenomenon.
It's driven by two factors, the local competition and the need to cover those expanded services, especially ECMO.
Those sign-on bonuses are basically the immediate price of admission for a hospital to get a seat at the table.
It is the cost to attract that talent, which is exactly why the national average for a sign-on bonus is $20,000 for perfusionists.
And sometimes hitting that $50,000 level for senior talent or those willing to move to a high-need area.
It's a stark illustration of the demand we were just talking about.
Precisely.
And for you listening, this is exactly why you should care about this obscure medical niche.
If you or a loved one ever requires life-saving ECMO support during a severe respiratory failure or needs a complex heart surgery, the availability of this specific, highly trained specialist is literally the barrier between life and death.
The machine cannot run itself,
No, it can't.
which puts hospital administrators in an agonizing position.
The total cost of ownership, the PCO, for a single senior perfusion provider in a competitive market is now hovering around $350,000 a year.
Wow.
And that's once you factor in benefits, payroll taxes, and continuing education.
That is a staggering number to digest when the revenue side of the equation is actively being slashed by CMS.
Something in the hospital's financial model has to break.
How do hospital administrators actually balance that math without going bankrupt?
They have to completely rethink their operational structures, which usually forces a brutal debate.
Do we keep our perfusion teams entirely in-house? as traditional hospital employees, or do we outsource the entire department to a specialized third-party vendor?
Our strategic staffing paper lays out the hidden costs of the in-house model brilliantly.
If a hospital wants to credential and manage a small 5-person perfusion team internally, the administrative burden alone costs them between $90,000 and $150,000 annually.
Just in overhead.
Right, that isn't clinical care.
That factors in the dedicated HR staff salary, specialized compliance tracking software, and the massive amount of revenue delayed during the 90 to 150 days.
That it takes for a new in-house hire to be fully approved by insurance payers.
And that administrative leakage is exactly why the outsourced model has become such a prominent lifeline.
Outsourcing offers a hospital budget clarity.
Right. Instead of dealing with unpredictable overtime spikes, costly on-call premiums, and the nightmare of paying external headhunters every time someone quits, the hospital just pays a fixed, predictable monthly fee to a vendor.
Makes sense.
The vendor absorbs the massive recruitment and retention risks which the hospital is eager to offload.
Plus, the outsourced model provides incredible supply chain leverage.
Okay, wait, explain that supply chain leverage, because I think people assume outsourcing just means swapping one paycheck for another.
Sure, so large perfusion service companies leverage their national scale to negotiate significantly better pricing on high-cost disposables.
Like the actual oxygenators used in the heart-lung circuits.
Oh, I see.
More importantly, they offer capital equipment leasing.
A single heart-lung machine costs hundreds of thousands of dollars.
Some hospitals save up to $500,000 up front just by leasing their equipment through their vendor rather than buying it directly.
That's huge.
It entirely removes the burden of maintenance contracts and asset depreciation from the hospital's balance sheet.
It's the classic difference between owning a high-maintenance historic home versus renting a fully serviced luxury apartment.
Yes.
With the in-house team, you own it, you have total control over the paint colors and the landscaping.
But when the boiler breaks at 2 a.m., it is your problem, your liability, and it's going to cost you a fortune to fix.
Exactly.
With the luxury apartment, the outsourced model, you pay a premium rent, but if a pipe bursts, you just call the concierge and it's handled.
But wait, I struggle to feel bad for the hospitals here.
If outsourcing saves them so much administrative hassle, hardware costs, and liability, why aren't they all just doing that?
What is the actual catch to essentially renting your most vital surgical staff?
Well, the catch is the cultural and institutional trade-off.
Yes, outsourcing solves budget clarity, and it cleanly navigates compliance hurdles.
Like Stark Law.
Right.
If I remember my hospital administration basics, Stark Law is essentially the anti-kickback, anti-self-referral regulation designed to prevent Medicare frauds.
Spot on.
Because perfusionists are wrapped up in the technical component of a surgery rather than billing Medicare separately, having them as contracted vendor keeps the hospital completely insulated from those legal ambiguities.
Exactly. The legal and financial boundaries are pristine.
But to address your point about the catch, administrators deeply worry about losing the soul and the organic culture of their hospital.
Oh, right.
When the most critical people in the operating room are essentially rented contractors, there is a recognized risk of losing institutional loyalty.
Outsourced staff might feel less invested in the hospital's long-term internal initiatives or cross-departmental training.
Because their primary employer is the vendor in another state, not the hospital they walk into in the morning.
But whether a hospital chooses to own the house or rent the apartment, they still face the exact same ultimate threat, keeping these highly sought-after professionals from quitting. Because whether you are the hospital HR director or the vendor's regional manager, turnover is the ultimate budget killer.
It really is.
And this is where the structural economics inevitably give way to human psychology.
Yeah, our sources dive into Victor Vroom's expectancy theory from 1964, which is prominently highlighted in the Walden University dissertation.
Vroom gives us a literal mathematical formula for human motivation.
It's fascinating.
It says motivation equals expectancy, which is the belief that your effort actually leads to high performance times instrumentality.
Which is the belief that your performance leads to a tangible reward.
Right, times valence, which is whether that reward is actually valued by you.
It's a multiplication equation.
If any one of those three variables hits zero, the total motivation drops to zero.
It is a brilliant framework because it forces management to look past just the dollar amount on a paycheck or even a $50,000 bonus.
So what does this all mean? I have to push back here.
Can you really reduce the bone-deep exhaustion of a 12-hour ECMO shift, the burnout of a high-stress medical environment, and the complexities of career satisfaction to a multiplication equation?
Isn't it, at the end of the day, just about the money at that elite level?
What's fascinating here is that the clinical data in the Walden study says no, it is absolutely not just about the money.
Really?
The study breaks down 4 major themes of perfusionist retention: job satisfaction, work-life balance, surveys, and compensation.
meaning the employee's voice actually being heard is a factor.
The research shows that while compensation must be competitive, like offering that market rate sign-on bonus, it acts more as a hygiene factor.
Meaning if you don't pay the market rate, they leave immediately.
But paying them top dollar doesn't guarantee they will actually stay.
Precisely. The real drivers of retention, the factors with the highest balance or actual value to the employee, are quality of life metrics. Flexible scheduling is the dominant variable.
We are talking about transitioning a high-stress team from grueling 5-day work weeks to compressed 4-day work weeks.
Or establishing a culture where, if the surgical board is quiet for the afternoon, the team is allowed to leave early without being micromanaged.
That makes sense.
Furthermore, management must actually utilize exit interviews and engagement surveys to create a trusting culture.
Employees want to know their feedback isn't just going into a corporate black hole.
That makes perfect sense within Room's formula.
If you are a perfusionist making $290,000, but you haven't seen your family on a weekend in 3 months because you are constantly on call, the balance of that money drops to zero.
Yep, you don't value the reward anymore.
And if you believe that performing flawlessly just results in you being rewarded with even more grueling shifts, which is a failure of instrumentality, your motivation collapses.
And the human capital cost of replacing that burned-out perfusionist, the recruiting fees, the delayed surgeries, the training time, is astronomically higher than the operational cost of simply accommodating a flexible, humane schedule.
Here's where it gets really interesting.
How does this loop back to solving our original problem?
We started this deep dive looking at a hospital trying to survive massive CMS budget cuts and a 7% decline in facility revenue.
Right.
So let's say an administrator has optimized their staffing model and they've retained their top talent by utilizing these psychological principles.
How does keeping a perfusionist happy actually protect the hospital's shrinking bottom line?
A highly retained, well-rested, mentally engaged perfusionist doesn't just improve the HR department's turnover metrics.
They literally protect the hospital's revenue through superior clinical quality.
Okay.
In modern healthcare economics, quality is the ultimate financial hedge against reimbursement cuts.
Walk us through the physical mechanisms of that.
Like, how does running a heart-lung machine perfectly translate to hard dollars saved for the facility?
Well, the sources outline very specific key performance indicators or KPIs that elite perfusion teams hit.
For instance, a top-tier perfusionist will consistently maintain a patient's activated clotting time, the ATT, over 400 seconds during surgery.
Because when a patient's blood leaves their body and enters the plastic tubing of a heart-lung machine, the blood naturally wants to clot.
Right.
If the perfusionist doesn't perfectly manage the administration of blood thinners like heparin, a clot forms in the circuit.
Which can completely ruin the machine or, far worse, cause a catastrophic stroke in the patient.
Exactly. That vigilant precision prevents devastating outcomes.
They also keep the patient's intraoperative glucose strictly below 180 milligrams per deciliter, and they meticulously manage blood volume and hemodilution.
Wow.
By hitting those precise physiological metrics, a top perfusionist keeps packed red blood cell transfusion rates below 15% for first-time coronary artery bypass graft, or CABG, patients.
Under 50% is incredible.
And from an economic standpoint, blood products are incredibly expensive.
Highly expensive.
Every single unit of blood saved, every single day a patient doesn't have to spend languishing in the intensive care unit due to a postoperative infection or a neurological complication, saves the hospital astronomical amounts of money.
Yeah.
We are operating in an era where CMS actively penalizes hospitals for readmissions and extended lengths of stay.
The perfusionist's flawless execution in the operating room directly shields the hospital from those severe financial penalties down the line.
It's remarkably similar to Formula One racing.
Oh, how so?
The CMS cuts mean the racing team suddenly has less money to build the car.
The development budget is slashed.
But instead of panicking and buying cheap parts, the team invests heavily in an elite, perfectly synced pit crew, the perfusionists.
I like that.
Because if the pit crew is perfectly rested, highly motivated, and flawless in their execution during a chaotic race, the car never breaks down on the track.
They avoid the catastrophic million-dollar crashes, and that consistency is what ultimately saves the season's budget.
That is exactly it. An upfront investment in elite human expertise undeniably pays for itself by preventing systemic, costly errors that the hospital can no longer afford to absorb.
Which brings us to the big picture of what we've unpacked today.
We started by looking at macro-level federal policy, with CMS applying permanent efficiency cuts and slashing relative value units.
Because they assume advanced technology is making medical procedures inherently easier.
Yeah, and we contrasted that with the reality on the ground.
A highly competitive $290,000 labor market, including those massive sign-on bonuses.
driven not by a wave of retirements, but by the horizontal expansion of life-saving intensive technologies like ECMO.
demanding specialized attention across the hospital.
Right. We weighed the brutal administrative costs of keeping a clinical team in-house against the budget clarity, supply chain leverage, and cultural trade-offs of the outsourced vendor model.
And we saw how applying Victor Vroom's psychology from 1964 proves that preventing burnout with a 4-day workweek is just as crucial to a hospital's survival as the massive sign-on bonus.
And ultimately, how that retained elite talent literally stops a hospital from bleeding money through superior, complication-free clinical quality.
For you listening, whether you are managing a corporate team in a totally different industry, analyzing health economics, or just seeking to be well-informed about the systems operating around you, the core lesson here is universal.
Policy decisions made at the highest levels in the quiet, isolated halls of Washington always have deeply human ground-level consequences.
Absolutely. You can change the reimbursement numbers on a spreadsheet to balance a federal budget, but you cannot bypass the human reality, the stress, and the required skill inside the operating room.
This raises an important question, and it's a thought I want to leave our listeners to ponder.
CMS is actively justifying its payment cuts by assuming that AI and new technology are making medical procedures more efficient.
Ostensibly requiring less human effort. But as the exploding demand for specialized perfusionists shows us, the exact opposite is happening in practice.
The more advanced our medical technology gets, like an ECMO circuit capable of keeping a patient's cardiopulmonary system functioning for weeks on end, the more heavily we rely on highly skilled, intensely focused, irreplaceable human beings to vigilantly manage that technology.
Will the ultimate premium commodity in the future of automated healthcare simply be human expertise?
Because at the end of the day, no matter how much pressure builds up in those hospital pipes, and no matter how technologically advanced the valves become, you still need an expert who knows exactly when, why, and how to turn them.
That's our deep dive for today.
Thanks for tuning in.
Okay. Well, to me, that was very, very, very good. And again, I want to remind everyone that that all is a function of what I inserted into the system.
The data that you put in.
Right.
Right.
We had to go through several iterations until it was, in my view, satisfactory.
Mhm.
But with that said, I want to move forward, if I
Mhm.
may, and go ahead and give these slides, which I think will help immensely in being able to reinforce and understand this. You and I can have
Yeah.
our usual dialogue. So let's go ahead and throw those slides up, David, and we'll get started. So we're going to look at navigating the perfusion squeeze, and this perfusion squeeze also means the squeeze that the hospitals are experiencing. Now, I'm coming at this from the contractor's perspective. There's always going to be these two concepts of does a hospital contract or does a hospital have in-house staff?
I've been
And
asked this, by the way.
I'm sorry?
I've been asked this, by the way.
Yes.
And obviously don't have the answer because,
Well, I don't.
that's why I'm glad I'm here today. I'm glad
Yes.
to hear you talk about this.
Yeah, I don't think there's a simple answer to it.
Yeah.
I think that I think it depends, and I could have asked another question of the AI generated speakers, and I do believe that data is in there
Mhm.
somewhere, but I do believe that it is a matter of volume.
Mhm.
I
Okay.
think that a large institution like the Texas Medical Center, whether it be Methodist or whether it be Memorial or whether it be
Luke's.
St. Luke's,
Yeah.
the in-house model makes a lot more sense
Right.
for them.
Yeah.
Those places need and almost thrive. They don't exist without these institutional norms.
Mhm.
And it's very hard to have that when something as integral as perfusion
Mhm.
is a separate entity from yourself. Very, very hard to do that.
Yeah.
Where I think contract perfusion is at its best for a hospital are hospitals doing 500 or less procedures per year, even if they have a large ECMO service line as well,
Mhm.
or ECMO, their an ECMO center of excellence, or they have an ECMO unit, or whatever the case
Sure.
may be. And I think that in those cases, it makes much more sense to contract. And I think that the contractors that are financially, I'm talking about,
Mhm.
and I think that the contractors, um, the ones that provide the service, are going to be judged not solely on the financial portion of it, but on my three key elements that I talk about all the time: dependability, responsibility, and accountability. If you don't have all three of those things, you have nothing. But there's an element that I think we, Houston
Mhm.
Expert Pro Technologies, I'm going to take my MediWeb hat off and I'm going to put on my HET hat here for a
Mhm.
minute as the CEO of that organization, is integrating into the culture of our customer hospital.
Mhm.
I have worked for, in my very long career, several contract organizations,
Sure.
none of which ever spent, in my view, even a fraction of the amount of time that I spend in helping our staff understand the import of and observing that
Mhm.
that element is actually met with becoming a part of those hospitals. And if you go to any of our contracted hospitals,
Mhm.
you will find that there are most people in the hospital that really think we just work at the hospital.
They do.
And
Yeah.
I think that is something that's an element that differentiates a really good perfusion service contract company
Mhm.
from a perfusion service contract company that is just in it for the money.
Yeah.
There's a difference in that, and really understanding what's important to each facility, because each facility has some universal concerns, which are the various quality metrics, but you also have to take into consideration their cultures, and their cultures are different.
Mhm.
The three big systems here in Houston, Methodist, Memorial, and St. Luke's, all have a somewhat different cultural feel and traditions.
Absolutely.
And
Mhm.
we are very good, and I'm very proud of how we are able to work within all of those, regardless of where we may be.
Yeah.
Because that's something, again, I believe differentiates
Mhm.
HET, Houston Expert Pro Technologies, from other providers, other service contract provider companies.
Yeah.
So let me get through this, but that's my view on that.
Yeah.
Did I answer the question?
You did, and I agree with you 125%.
I
We're
think most
chameleons of sort.
I think most people. Well, I think
Yeah.
most people would,
Yeah.
but it's not just.
And
It's
you're
not.
absolutely
But
right. They think we
the
work there.
chameleon is an imitation. So
Yeah, we're not. We actually
explain.
are.
No,
Like, right.
at my core,
Mm-hmm.
and I think this is an important distinction. And I'm not saying you were wrong in saying that. I'm just clarifying, if I may, because it's an important concept to me.
Sure.
That we're not that. We're not chameleon like. We genuinely understand how
We do.
important that is,
Yeah.
and we're liked.
Yeah. And I
You
feel
know?
it's because of the way we conduct ourselves there. All of our people know all of the staff.
Yes.
It's very rare if we're in the ICU, the CV ICU, the OR, that somebody doesn't know who we are.
Yes.
You
And
know?
we value them.
We value them,
We
right.
help them.
Yeah.
We try to we do our very level best
Yep.
to understand, to know
Yeah.
what their expectations are
Exactly.
of us within their corporate
Correct.
structure, their corporate conduct expectation. A lot of it's very common sense, but the nuance of it is really important, and it makes a difference to directors of various different
does.
departments we go to if they feel we are doing that.
And it's important, like you said, you can't go to Luke's and act like you would act when you're in Methodist. You can't go to Methodist and act like the way you would act at Herman.
Correct.
You know, you have to act accordingly
Yes.
to the environment you're in because of exactly what you said. They're very different cultures.
Yes, but we
You
also
know?
have very low turnover. We also have, and that's one of the other things, the other elements that I think are really important for us as an organization, is that our tenured people. I mean, we have people that have been with us for a very long time, for the very almost the beginning of this organization.
Right.
So we've added,
Mhm.
but we don't have a whole lot of turnover. Our
Yeah.
turnover rate is very low.
Oh, that's important. People get used
It
to
really
this.
matters.
It matters, correct.
It really matters. Okay, let me get through this. Let me see, how am I doing on time? I got a little bit of time.
Yeah, a little bit.
So this is a very nice illustration of what was just discussed. You have these pincers that are squeezing the service line margins with CMS reimbursement at the top and labor market volatility just crushing the hospital's budgets with them trying to figure out, how do I provide this service line and not have it hurt us any more than it already is. And so if you look at the negatives, you have a 2.5% efficiency adjustment. You heard them talk about that. So the work RVUs, if you're an employee of a hospital, a physician employee, the hospital is measuring RVUs because that is what the hospital is going to get for your services.
Right.
And they have to pass on these cuts to their employees. Okay, I mean, that's just the reality of it. So that efficiency adjustment really matters. And then you have a 7% overall facility-based cardiology reduction. And why is that important? I'm saying cardiology, not cardiac surgery. Well, you have to remember there's a tremendous amount of peripheral services that are done. We'll talk a little bit about that moving forward here, where that income, that profit is used to help reduce the loss or to at least pay for, make neutral some of these service lines that are taking such deep cuts that it costs the hospital to have the service line. And cardiac surgery is one of the biggest things there is. You can't have an active cath lab if you don't have, a really active cath lab, though they are pushing for standalone outpatient cath labs. And if you get into trouble there, you have to get transferred via ambulance while you're being coded as opposed to being right in the hospital. But it exists.
Really?
It absolutely exists. So
and they don't have a high turnover. What's their outcomes?
they try. I think they try to. No, I think they really try to be very selective with who's going to go there. Okay, these are diagnostic.
Yeah. Okay, they're not going to take on an instant.
They're not going to do a TAVR, although in Germany they do.
Huh.
In Germany they do TAVRs, but they call them TAVIs there. But TAVRs, you know what the difference between a TAVI and a TAVR is?
Location.
No. TAVI is actually, it's a transcatheter aortic valve implantation.
Okay.
But in the United States, if you call it that, CMS will not pay it. They will pay it if it's a replacement. And that's just so the name change only has to do with how it has to be listed in order for CMS to activate the pay. That's why it's changed, different name. So there's your answer to that.
Terrible.
If you didn't know that, that's the craziness of it all. But then perfusion, we have lived under this assumption, and I think during COVID, it was partially true, where you had people quitting. But really, it's just quitting, retiring early. I'm done, I'm out. But you also had a lot of people going here and there to cover ECMOs and to make $1 million, which they never made, by doing that. So you lost an enormous number of people from communities, just like Houston, for them to go run up to New York or to run over to Chicago or to run over to San Francisco and make a lot of money covering ECMO. And they essentially abandoned their own homes. And I have very mixed feelings about it. I'm a loyal person. I believe in loyalty. So I have mixed feelings about it. I can understand it, but then I don't understand it. And I don't want to say exactly how I feel because I think that I don't want to be criticized for having such strong feelings one way or the other. I'm going to try to be understanding and say that everybody has a perspective, and I have. So with that said, I think the shortage isn't necessarily we don't have enough perfusionists. I think the shortage is because we have perfusionists doing all these increased horizontal things, like they talked about. ECMO's increasing. NRP, that's just coming up, and it's going to continue to increase.
Yeah.
There's going to be angiovac. There's going to be all of these different services that we are able to do, you need us to do, and that is creating a relative shortage, not because we have fewer perfusionists, we have the same number of perfusionists doing even more things. So people are picking and choosing. There's perfusionists right now that are leaving clinical practice in cardiac surgery and doing only NRP.
Yeah.
That is all they are doing.
Right.
And so that creates a shortage back here.
Correct.
But it's really, you understand what I'm
No,
saying?
I 100%.
And of course, the schools,
Yeah.
there's always a reaction, are just graduating people right now at what I perceive as an alarming rate. I would
That
say
pendulum that you
in
used to
the,
talk about.
yes,
Yeah.
pendulum I talk
Yeah.
about all the time.
Yeah.
However far it goes
Yeah.
in relative shortage, it swings back the other
Right.
way with more energy because it's way out there to a glut. And that is what I'm seeing.
Yeah.
I would say in the next 5 years, people are going to have a very hard time finding a job right out of school. And I think that people that want to move from point A to point B are going to have a very hard time to do that. I also believe that you will see massive, significant cuts in salaries by the end of the 5 years, you're going to see salaries lower than they are today. And yet inflation and everything else will go that way.
Right.
Because we have outpaced inflation at a almost ridiculous level. And it's great for us.
Right.
But what concerns me is the lack of regard for our profession moving forward. Because are we not supposed to be stewards of this profession for our younger colleagues that are
Right.
currently in school, or very young colleagues just graduated from school? So, I feel like we're failing in that regard. It's one of the reasons why I have such fights with organizations like AMSEC, because I don't really see them as looking out for the best interest of our profession, but rather the best interest of just a group of people who are in this particular moment of time. I think that's misguided. So that's my opinion about that. This kind of illustrates the raise, the 3.26 raise, a little bit lower if you're non-qualified physician or practitioner. Then you have this downward 2.5% efficiency adjustment. You have this 50% indirect physician expense allocation. So hospitals that may have been providing offices to their physicians, physicians who have their own offices, they're going to lose 50% of the money that they have for physician expenses. And then you have a 7% decline in facility-based cardiology services. Now, this can extend to peripheral vascular work as well, where they're taking things from the hospital that were really good at profit margin, and they're trying to now say, no, we're not going to do that in the hospital anymore. We're going to move that outside of the hospital, and basically you're losing that revenue, which helps to supplement everybody else in the hospital. And so, and this, I mean, that's not an unusual business model, because if you're making it impossible for you to do cardiac surgery, what are we going to do? Stop doing cardiac surgery? Well, I mean, we know that can't happen, but are we going to, it could.
Yeah.
This could hurt an awful lot, at the end of the day, patients who don't have access to cardiac surgery, because they're just going to have to limit it, or they're going to have to start saying, we aren't taking anything with an STS mortality risk greater than 2.5%. And we do an awful lot of them that are 3%, 4%, 5%.
Right.
And so that's something I think you really need to take into consideration. This is the same thing that they talked about, where you have a 28% reduction in these stress tests, a 27% reduction in RVUs from 14 to 10.5 for that one particular procedure, but that's just one procedure that's illustrated.
Yeah.
Interestingly enough, PCI is being maintained it's been revalued with complex codes, finalizing a neutral event effect. So, but PCI has been cut already before. They're just not going to further cut it. So as the surgical RVU pool is drained by targeted evaluations, high-cost support staff become exponentially harder to subsidize per case. That is the fundamental point that I've been making. The myth about the retirement age, again, that it's going to be greater than 50%. We heard what they said, and the data also says this in this slide. In 2024, only 74 certifications were lost, the lowest since 2000. Yet fierce demand has triggered a job hopping market. There is the reason for the shortage, the perceived shortage.
Right.
And has become a bidding war. I'm not leaving. I'm making all this money.
No,
If that's
yeah.
what's important to you. But again, that's changing, and it
Yeah.
is going to change. I give it 5 years top.
Also, it's
And it
the
could
rise
happen
of,
sooner than
of
that.
heart programs in smaller markets.
This is true too.
Now they're just doing more, or there's more heart programs now.
That's another thing. But we've
know?
seen a lot of heart programs close.
It's true too, yeah.
There's a
Yeah.
huge number that have
Yeah,
closed.
right.
And where that balance is, I'm not sure.
Right.
Should you be doing heart surgery if you only do 50 cases a year
Right.
and you're in the middle of nowhere? It's a serious question.
It is.
But
Sure.
if you don't do it, how does it affect the community that can't get to a larger place because their condition will not sustain a transport to a larger
Correct.
city?
Correct.
So it's a very challenging thing to make a decision on that. Centralization of care, like ECMO, cardiac surgery, has been debated for years and years and years. And, this country, though we have huge population centers, is mostly rural.
Yeah.
If you
There's
eliminate
no-
that, we got a problem.
Yep.
Here we see the typical iceberg model, average salaries, bonuses, sign-on and annual bonuses, and underneath the water that you don't see is the benefits load. In our organization, our benefits are roughly 33% of whatever your salary is. If you have to use locums for some reason, you can pay up to $200 an hour during vacancies where you are desperate. It's usually a little lower than that, and I think this is the high end. It depends on your market. One thing I didn't ask was, what is the reality of the different markets? So these average salaries are skewed by the New Yorks, the San Franciscos,
Exactly.
Los Angeleses,
Right.
the Miamis,
Right.
these places where the
Cost
cost
of
of
living,
living is
yeah.
so Chicago.
Right.
The cost of living is so
high.
high
Yeah.
that and that's one of the things that we have as a benefit here in Houston. It's a two-edged sword. Our cost of living here in Houston is
Very low.
very reasonable compared to
Very,
most
very
places in the
reasonable.
country.
Oh, God, yeah.
But yet people are demanding these much higher salaries
They
and
are.
saying, you know what, hey everybody. Okay. As soon as we get on YouTube, let me know. We're back up. We're live.
Alrighty.
Okay. Well, we had some fun here. I said uh-oh,
Yes.
and
But y'all didn't see the.
it's very bad when you say uh-oh. But we had a pop go off, and all of our electricity got shut down, and then we finally got it restored.
That's
so
the worst
we're-
combination too. A pop followed by an uh-oh.
Yes, a pop followed by an uh-oh. Yes, yeah.
Yeah.
Can I tell a side story? A side story, but those were actually the last words or the last sounds uttered by Commander Scobie of the Space Shuttle Challenger, and that was on the recording. And he said, uh-oh, and at that point, the Challenger exploded. Yeah. And so, uh-oh is serious. Are we are up? Okay, welcome back. Had a little problem. Okay, so back to this slide that I don't think they can see. So so on the left side, your salaries and all that. On the right side, your benefits. I was saying that HET were about 33% of your salary is in benefits. But you have to take into consideration using locums when necessary. Credentialing and HR is $90,000 to $150,000 a year for a 5-provider team, because it takes 3 months. It takes us 3 months to get somebody privileged at hospitals. We could hire somebody and have a 3-month wait before they can literally do anything. Hospitals will have hospitals can have the same issue, but we also have to then train them. We have to get them familiar with, potentially multiple hospitals. And of course, any hospital would have to get that person comfortable working there and everyone working with them.
Correct.
The true cost, or the total cost for ownership, TCO, is about $350 annually. Now, I think it's a little lower than that here in Houston. It's a little lower than that for us, but it's not that much lower. It's not so much lower. It's like, that's a ridiculous number. It really isn't that ridiculous. And and then you have overtime pay, callback pay, call pay. Are all kinds of elements here that a hospital has to take into consideration. So you're not a big giant medical center that's just 24/7 and people are working shifts, but you are doing, your volume goes up and down depending on certain circumstances. It's going to be very hard to compete with the with keeping people in house versus contracted. The cost analysis is just not in favor of it. But again, you also have to be aware of, yeah, okay, I'm saving money, but am I ruining the morale of my operating room or my ICU because these people don't give a damn about us? And that's another element of it, where when you're picking a perfusion service contract company, that should be the first part of everybody's conversation. How are you local to me? And I think that's very important. I think there's a place in our world, I guess, for these large national contract companies, and they say, hey, if anything happens, we'll just run somebody straight to you. We could get people there right away. Well, okay, you still have Texas licensure to deal with. That takes time. Let's say they just kept the Texas licensure. They have people that just have these different licenses around the country so that they could actually go there. They don't know any of your people. You have no idea who they are. They haven't been vetted out by you, and you're trusting that whoever's coming in there isn't somebody that just couldn't fit in anywhere else, and now you're stuck with a misfit with the organization that you're contracting to. So these are things that I think are really important. I believe my preference is that local, dedicated, community-based perfusion service contract companies is your best bet when it comes to having a team that's cohesive and works within your culture. That's my belief.
And this is why you don't go outside Houston, correct?
Correct. That is right. I do not. I do not go outside of Houston.
Yeah, you told me that.
It's true. True story.
Yeah, you told me that.
I've been offered many times.
But you just don't.
Well, no, because I, no, I don't want to do that, because then I lose the element of being a part of this team.
Correct.
Because I can't be everywhere at once. I can be anywhere in Houston, but I can't be in Houston and Oklahoma City at the same time. It's not possible. So, yes, I have always deferred anything outside of the confines of Houston, and that's why I named the company what I did, which is Houston Extracorporeal Technologies. I didn't name it National Perfusion Services Incorporated or some other name. I won't mention. So here we have financial probability, in-house model, financial predictability, operational scalability, administrative burden, institutional control. In-house model for this, you have high budget volatility, overtime, locums, and vacancies. In the outsource model, it's a fixed fee with budget clarity. Operational scalability is rigid, vulnerable during, especially during turnover. Nationwide travel roster ensures immediate backfill, but I just talked about why I do not think this is really a benefit. It can be if you just want a warm body. Oh, I didn't mean to do that. So sorry. Come back to this. Administrative burden, high hidden HR credentialing costs. Vendor absorbs it. Recruitment compliance friction is therefore resolved, taken out of the issue of the administration of this hospital. Institutional control, well, if you own them, you can basically have them do whatever you want them to do. If the schedule is light and you want them to do cell savers, you can have them do that. If the schedule is light and you want them to go up and help in the cath lab, you can do that. If the schedule is light and you want them to transport patients, you can do that. The downside of that is no one will stay working with you. They'll quit. And that's a harsh reality. Low shared, but it's true. Low shared requires deep trust into vendors' clinical oversight. That is, again, what I am referring to when it comes to a local group that you have a relationship with. An administrator of a hospital and the CEO of the perfusion organization should not be 3,000 miles away. Then you have capital. Without getting into big details, a hospital has a capital budget. It is very hard for them to ever get everything that they really want or need. When you do lease that from a contract company like ourselves, you remove that. Now you don't own the equipment, has about a 10-year life cycle, but you also don't have the preventive maintenance part. You don't have shutdown because something isn't working. It is the contractor's responsibility to make sure that their device, if a case is canceled because your service provider who is leasing you equipment does not have what they need to do a procedure, that is a very good reason to seek help elsewhere. It is not governed by Stark and anti-kickback clarity, although that was attempted through Mike Bradner back in the old days of MBA Medical, where he made an effort to make Louisiana not allow perfusion service contract companies to provide disposables as well as perfusion services. And that was a very big fight, but ultimately he caused enough heartache and headache and trouble that Louisiana became a state that does not allow for that. I think it's evolved since then, but he did it because he was at the time selling a product that was inferior, and other people, the contract companies, didn't want to use it. And so that was his methodology. I think it was very, again, it was something not in the interest of perfusion. It was of interest to his pocketbook. A lot of people make those choices. And I can understand it. We're all selfish human beings. We are human. But I disagree with it. These metrics that you see here, basically us keeping them either below or above the minimum values. You get the 15%. You get an adjustment for your essentially pay for performance, PFP, and that's something that's very important to hospitals. And then the anatomy of burnout from Walden University, you see here organizational stressors, long hours, poor management, emotional exhaustion, physical mental depletion, depersonalization, and cynicism turns into voluntary turnover, which then exacerbates this and then continues this loop. And usually this just gets tighter and tighter and tighter and tighter and tighter until it disappears into a black hole. Data indicates that 46% of staff retention is directly predicted by stated motivation and job satisfaction, not just base salaries. Turnover is a symptom of failed systemic architecture. This is very important. And this is that Vroom model from Victor Vroom, 1964, that the AI speaker discussed. You have expectancy, which is the effort for performance, work-life balance, flexible scheduling, things like that. You have instrumentality. Are you listened to? Are your concerns? Do you have access to your leadership? And does your leadership care to know what you think? And then you have balance, which is what is the value of the reward to you? You can pay the highest salary you want, but if the expectation is work-life balance, then it doesn't matter how much salary. They'll do it for a little while, but then they'll quit. They'll make the money and quit. So providing purposeful roles, market competitive pay, and addressing the specific demographic needs of a younger workforce. We have many people in our organization. Some are married with children. Some are single with children. Some have young children. Some have old children. Some are motivated by, I want to work really hard and just keep and just get as much experience as I can. They have a different motivation. Some are motivated by money, and that's okay too, because we do have extra earned opportunities.
We do.
And there's a relatively small group of people that are always jumping on those opportunities. But it fills a need for them. And so I feel like as an organization, what we've tried to do is work with people who have various different realities. And one of our team members, who I love dearly, Melissa McNutt, said it best one day. We met, and she said, "I'm just in a different season of my life right now." And looking at her in totality as an employee, what the value that she brought to this organization, we adapted to help her. Now,
Correct.
and it has paid dividends as far as I'm concerned. And that season will change again at some other time.
Life,
Other
Joe, it's
people's,
life.
yes, other people's seasons will change.
Yeah.
Single people will get married, they'll get pregnant, they'll have children. There's all of these things that a manager has to recognize, and they also have to do it in such a way that the other members of the team don't feel put upon. So you're making your some people are higher maintenance than other people for various different reasons. But what you always have to teach people and remind people of is that, oh, for the grace of God go we, including you, and at any moment there can be something that you need that kind of support for. That's cultural. That starts from the very top.
Mm-hmm.
And you want that culture in your organization. If somebody cannot understand that, for whatever reason, they may not be better, may not be good for your organization.
Yeah.
Sometimes you have to understand that this person does not, just like a hospital, this person does not meet our culture. Well, if you're a hospital employee, you're dealing with a lot of bureaucracy to get rid of that person. If they're a contract person, you call the contractor and say they can't come back to my hospital.
Right.
It's that simple.
I know. It is. It's that simple with contractors, but it's also like, like you said.
But then you
we
have to
train them.
then you have to,
You have to.
but then you have to adjust again,
Yeah.
because just because they didn't fit in there doesn't mean they don't fit in elsewhere.
That's a good point.
You
yeah.
have to evaluate the person not on one thing,
Right.
unless it's egregious. You can't do that. You have to understand why. What is the reason? And sometimes it's a matter of good communication. You have to be an advocate for your employee, even in that circumstance,
Mm-hmm.
and try to see if, take a little break away from the circumstance, and then see if there's a way, a pathway back. And that takes finesse, but it also takes having a relationship. The owner
Yeah.
has a relationship to the owner
Mm-hmm.
of the institution, the CEO,
Correct.
CEO to CEO, and you try to bridge that gap.
Correct.
You deal with the person and what the issue may have been, and maybe there is something they could do differently, but there's always that opportunity.
Mhm.
You cannot do that if you are in New York
Yeah.
and you're dealing with somebody in Houston. Like I said, that's my reason.
Yeah.
So that's very important. And then you have this to transform administrative friction into clinical throughput. So perform a true spend audit. Hospitals who are making decisions about whether to do contract or in-house need to take heed of this very much. And perfusionists who are running contract companies need to also take heed of this. Model specialty impact. Map the 2026 decrease in the facility reduction and efficiency cuts against your specific case mix. Assess recruitment pipelines. I wouldn't consider a $50,000 sign-on bonus, but $20,000 is probably not unrealistic,
about to say,
unless you're in New York
20
or
20
something.
to
You go into
25 to
Melbourne,
30 is-
Australia, you're leaving the country. I mean, I can
Yeah.
see that. Deploy the room framework, which we discussed just a minute ago, where you look at what is important to each individual person and see if you can tailor their employment with you to meet those needs to avoid turnover. Turnover kills every organization.
Mhm.
And consider the hybrid pivot. Retain core clinical leadership while outsourcing specialized needs, NRP, locums, capital equipment to cap financial risk. You can do this model also where you have employed perfusionists, but all of these other things are done separately. The problem with that model, I was going to tell you up front, is if your caseload that they're normally operational for has gone down, people are not going to be very happy with them sitting around or going home early or not having any responsibility for these things that the hospital is paying infinitely more money for, because it is not within the purview of that particular group. So you have to take that into serious consideration when you contemplate these things. And I believe that's my final slide. It is. Do you have any questions for me, sir?
No,
Does
not-
anybody online have any questions
Yeah.
for me?
For me, I kind of just asked him as we went along.
Okay.
um,
No, that's fine.
yeah.
Magic, anybody have any questions? Okay, very good. We don't have any questions, and that's probably because I talk so much, nobody could get a word in edgewise. I want to thank everyone for being here. Next week, this is very important. I do want to go over this real quickly, and that is We are going to have Ed Delaney and Tom Stapleton, two of the leaders within the perfusion community. And they are going to be talking about managerial approach to 5 critical perfusion conversations. See, I teed that up for them. And then what does a competent surgeon really want in a perfusionist? And that will be Vivek Patel, MD, Dr. Patel, who, a different Dr. Patel, you're all named Patel.
We're all Patel.
And he'll be coming to us either live here in the studio or possibly virtually, but I work with him here in Houston. And I think he has some very good perspective on what he really does want in a competent perfusionist. What are his expectations? I like hearing it from the source. With that said, I'm going to bid everyone adieu, and thank you so much. Thank you for your patience with our little hiccup that we had with our electricity. Wasn't our fault. It wasn't a technological glitch on our side. It was just the city decided that we had used enough electricity for the day, apparently, or we didn't pay our bill, one or the other. And I will see you next week, Wednesday, March 25th at 11 a.m. Same time, same station. Thank you very much. Peace out.
Bye-bye.